Oh, there we go. All right, we're good. Let's start over. 3, 2, 1, and we're live.
Welcome back to the Governor's Opioid Response webinar series. My name is Josh Miller, and I'm the Opioid Response Project Manager. Before we get into today's webinar, I want to remind everyone that the Opioid Response Summit will be an in-person event at the Cross Insurance Center in Bangor on July 11th. This is on a Monday and will be an all-day event. The event will be organized around our 4 areas from our strategic action plan. They include prevention, treatment, harm reduction, and recovery support. We will be showcasing the most successful activities we have around these 4 areas. The title of today's webinar is Responding to the Epidemic Within a Pandemic, Shatterproof's Approach to Addressing Addiction. Shatterproof is a national nonprofit and will be discussing ATLAS. ATLAS stands for Addiction Treatment Locator, Assessment, and Standards Platform. This webinar is co-sponsored by Healthcare Purchaser Alliance of Maine. The Healthcare Purchaser Alliance advances value in healthcare through collaborative and engaged purchaser action. Just a reminder, if you have any questions, please share them in the Q&A opposed to the chat. We will try to answer all questions during this webinar. Any questions that we can't get to, we will post answers and update them to the Summit webpage on a later date. I'd like to introduce Trevor Putnatsky with the Maine Purchaser Alliance. Trevor resides in Yarmouth, Maine, and has his master's degree from the University of New England. He is a strong advocate for healthcare value and has been a leading voice in advancing quality, affordability, and access for over a decade at the Healthcare Purchaser Alliance. He has great connections within Maine's healthcare community and believes that collaboration across stakeholder groups is essential to develop viable solutions. At this time, I'll turn it over to Trevor.
Thank you for that, Josh. And it's a real pleasure to be here with everyone. As Josh mentioned, I'm Trevor Putnatsky from the Healthcare Purchaser Alliance. And we are a small nonprofit organization really dedicated to, like Josh said, trying to advance healthcare value in the state of Maine. And by value, we mean affordability and high quality care. So I'm really thrilled to be having this conversation with the folks at Shatterproof. I think we share a lot in common as organizations. And I know you all are here to listen to the Shatterproof folks, but I thought it might be helpful to provide a little bit of context around the opioid epidemic in Maine before we get started here. So I think everybody realizes that we have a real opioid problem in the state of Maine. You know, we've been talking about this for well over a decade, you know, as long as I've been working in this field. But I think in the last couple of years, it's really started to take a back seat to everything COVID that's been going on, which is really unfortunate, I think, because the opioid epidemic has really only gotten worse over the last couple of years and really substantially worse. So actually prior to the pandemic, after 2 decades of year-over-year increases in opioid deaths, we had just begun in 2018 to see a slight decline. And there was some real optimism that we might be having an impact on this problem. But then the pandemic rolls around and we saw really significant increases in overdose deaths. So in 2020, we saw a 36% increase in overdose deaths in Maine over the prior year, and that represented 515 Mainers. Then in 2021, we saw an additional 23% increase over the prior year. That was another 636 Mainers that passed away due to overdoses. And I think, you know, a lot of you have heard this is being driven largely by fentanyl flooding our market. It's a much more potent, deadly drug that's finding its way into a lot of the substances that people are using. But compounding the fentanyl problem has been a real epidemic of isolation and behavioral health problems due to the pandemic. We also have a real access problem in our state. So, you know, if you are someone that's finally ready to get treatment, there's a good chance you're not going to be able to find a bed or inpatient facility to be able to get treatment, let alone find one that is evidence-based and high quality. When we heard about Shatterproof at the Healthcare Purchaser Alliance, we were really excited to have this resource to not only identify where these treatment facilities are, but to identify the quality and evidence-based treatment facilities that exist in the community. So it's my sincere hope that we get a lot of engagement around this issue, a lot more awareness, and we start to put more resources in place across the state of Maine. And that we also have much more open conversations, because I think another real contributing factor to the problem of the opioid epidemic is just the fact that it's so stigmatized. And I know with the employers that I work with, almost no employees are coming up and talking about their opioid epidemics. They don't feel comfortable. They feel like they may lose their job, or there's some repercussion to talking about it. And this is something we really, really need to get a handle on here. I think we all know people that have been impacted by this. I mean, just since I left high school, I know 6 people in my class, and I did not go to a really large school, but 6 people that have overdosed and passed away since I graduated high school. And I'm sure every single person in the audience here knows somebody that's been impacted by this. So I think we really need to bring this conversation to the forefront. And that's another thing that Shatterproof is really helping with and taking a leading role in. So with that, it's my great pleasure to introduce Gary Mendel. I'm going to take a minute to read his extremely impressive biography here. Am I saying your last name right, Gary Mendel?
Yes. Thanks, Trevor.
Gary is the founder and CEO of Shatterproof, which is a national nonprofit dedicated to reversing the addiction crisis in the United States. After losing his son Brian to addiction in 2011, Gary founded Shatterproof to spare other families the tragedy his had suffered. Since founding Shatterproof, Mr. Mendel has been recognized as a national leader in the addiction space, working to transform how opioid and substance use disorders are treated. His priorities include advocating for state and federal policy change, ending the harmful stigma of addiction, and supporting and educating our communities. Mr. Mendel has testified in front of the President's Commission on Combating Drug Addiction and the Opioid Crisis, and his opinions are frequently reflected in the media. He's a member of the National Quality Forum's Technical Expert Panel for Opioid and Opioid Use Disorder, and is an advisory member of the Opioid Policy Research Collaborative at the Heller School for Social Policy and Management at Brandeis University. Before Shatterproof, Mr. Mendel spent decades as an entrepreneur. He founded HEI Hotels and Resorts, a multi-billion-dollar company that oversees a portfolio of approximately 70 first-class hotels. Mr. Mendel received his BS from Cornell University's School of Hotel Administration and his MBA with distinction from the Wharton School at the University of Pennsylvania. So with that, Gary, I'll let you take it away. Thank you so much for joining us here. And I'll just reiterate one more time, if you have questions, please put them in the Q&A box, and I'll relate them to the speakers. Thank you.
Great. Trevor, thank you. And thank you all for joining us here today. We all really appreciate it. As Trevor mentioned, I don't have the background that Trevor has. I came at this from a different perspective, as Trevor mentioned. I was raising my family, growing my business, and my older son, Brian, struggled with addiction. Like many teenagers, he tried pot and beer at 14, the year as he was getting into high school. And for many, he became addicted. That led to Brian going to 8 different treatment programs over 8 different years, 8 years in a row. And he really, really tried his hardest. But as Trevor also mentioned, in October 2011, I received the phone call that no father wants, that my son Brian had just passed away. What was so tragic beyond that was Brian had not used a substance in 13 months, and he was 25 years old. But equally tragic, it wasn't just addiction that took my son's life. It was the feeling of shame he had every morning when he opened his eyes. feeling like an outcast all day long, that caused him to wake up that morning, research suicide notes, write a note of his own, and take his own life alone. And he wrote about in that note, he wrote about being ashamed, how the stigma just, destroyed him, how he just didn't feel worthy. And he also wrote about the treatment system, that they really didn't, he went to 8 different programs, they were all doing 8 different things. Good people there, but following different ways of approaching things versus someone with heart disease or any other chronic illness being treated within the framework of what they're taught in medical school and what the science shows. So obviously after that, it doesn't get any worse as a father. And I really the only thing that kept me alive in those first couple months was just laying in bed and reading and focusing on the Serenity Prayer. Accepting what I couldn't change and thinking about changing what I could. And that started to transition to a different thought, which is, what could I have done differently as a father? I just needed to know, even though I couldn't change it. But then, what could be done to spare other families of the tragedy my family had suffered? So because I owned my own business, I had the ability to take some time, what I thought would be 3 months away from my business, and travel the country. I was in Washington, D.C. a lot, meeting with the federal agencies. I traveled the country, meeting with the leading researchers. And I learned so much in that first 3 months that I hadn't known. How big this disease was. 1/4 of American families, mother, father, son, or daughter, it's in their family or more. 3rd largest cause of death in the country behind heart and cancer. It's mainly about our children. 8 out of 10 of those addicted today, I learned, became addicted before their 18th birthday. But the biggest thing I learned, which destroyed me all over again, was I learned that our federal government, in the decades prior to my son passing away, had provided grants of tens of billions of dollars to researchers all across the country. And those researchers had successfully used that funding and created a wonderful body of knowledge. Knowledge that had proven to randomly controlled trials, without any doubt, if our families, our communities, and our healthcare system did A, B, and C, significantly less of our loved ones would use substances and ever become addicted. And for those who did develop this disease, if our treatment system did X, Y, and Z, success rates into recovery and full and fulfilling lives would be remarkably higher at the same success rates of those being treated for any other chronic illness, like hypertension, with heart disease, or diabetes, etc. But what destroyed me was I learned that all this information was sitting in peer-reviewed medical journals, and hardly any of it was being implemented. As a father, reading about information that could have saved my son's life, prevented me from having to go to a cemetery and bury him, either through prevention or treatment, and it was known, it was there, and it wasn't being implemented, that's worse than having to bury your child when you know that it didn't have to be. But then, coming from a background in business, I also saw an opportunity. It was the answer to my second question. What could be done to spare other families of the tragedy my family had suffered? Block and tackle. Let NIH worry about new research. What our society needed was an organization that would unite millions of Americans, states, companies, associations, advocates, families, and ensure that this information that existed was implemented as NIH developed new research. And with that, I decided to leave my career in business. I spent 2 years building a business plan and have dedicated my life to this cause. And that was the formation of Shatterproof, with a vision to do exactly what the society needs. Implement, block and tackle, nothing creative. That was the formation of Shatterproof. So with that, I'm just going to, again, thank you all for being a part of this and listening. Carolyn's going to put up a few slides to walk through a little bit about Shatterproof, and then I'm going to turn it over to Carolyn that will go much deeper into one of our programs, our quality measurement system for addiction treatment. So with that, Carolyn, if you go to the next slide. If there's anything that I learned in business, is focus, 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 the basic 80-20 rule. There are a lot of things that we can all do to reverse this epidemic and save people's lives, keep people out of cemeteries. So, but we can't do it all. So we picked 3 areas that we thought were really important, would have a high impact on saving lives and the quality of people's lives, and let others do other things. These are the 3 things. Revolutionizing the treatment system, breaking down and ending the stigmas associated with this disease, and supporting and empowering our communities. And I want to highlight the quote underneath that, which is, everything we do goes through a lens of not only helping people today, but changing the system. Shatterproof will never be large enough to help 300 million Americans. But Shatterproof is already large enough, and it's already doing so, is we've created programs and we're forming partnerships to change the system. And the system then will go on for generations, for our children, our grandchildren, our great-grandchildren. We change the system, and the system keeps going unless someone changes it back. That's what we're focused on. So in these 3 areas. So next slide, please. Just, we're everywhere. We're forming programmatic features that no one sees in a lot of ways. And we're also out there changing policies, bringing people together in events, spreading the word in a variety of ways. Next slide, please. So let's talk about stigma for a second. Next slide, please. First of all, before we even go through this slide, why stigma? You might say, if there's only 3 things you're going to focus on, why is stigma in the top 3? Take John Doe or Susie or Johnny tried drugs when they're in high school and become addicted, or Susie and Johnny get hurt playing sports and they got prescribed 30 days of opioid and became addicted for whatever reason. Think about the impact of stigma. 75% of Americans don't think that someone addicted has a disease. They think it's poor character. 51% of Americans are unwilling to associate with someone that they know has a substance use disorder as a friend, a coworker, a neighbor, or marrying into their family. So if you're Johnny or Susie, are you going to tell your parents you have an issue and go to treatment? No, you're going to hide it. You haven't read that survey, but you can feel it. You know, if anybody knows, you're going to lose half your friends, or you might not get a job. So you're going to hide it. Let's say your parents find out and they convince you. Can you find a provider? Well, maybe not. Literally 1/4 of primary care doctors in this country will not treat someone addicted to opioids because they don't want those people in their waiting rooms. It may hurt their practice, their reputation. That's a fact. Half the doctors in this country don't even think it's a disease. Half. Let's say you find a provider, you get through that hurdle. Are you going to be able to afford it? There's a national law that says payment models for this disease have to be consistent with other diseases, but it's not always followed. Let's say you get through that and you can afford it. Can you find a provider that's following evidence-based practices? Chances are not. Because a lot of providers, through my experience and through data, so it's a fact, are wonderful people. But a lot of them haven't been trained and educated in what the science shows that is most effective and are not following evidence-based practices. But let's say you get through all those hurdles, Johnny or Susie, and you get through all of them and you go to the best treatment program in the United States. You still enter society where half the people in this country don't want anything to do with you. Some of those will say, society doesn't know what they want. They don't know anything. I'm strong, I'm smart, I'll be fine, and I'll just keep it quiet. But most internalize it, like my son did, and think, I'm not worthy. They're right. I am not worthy going up to my neighbor's daughter and see if she wants to go out for lunch. I'm not worthy of living in a nice neighborhood or getting a good job. I'm just not worthy of it. That's why stigma matters. So moving quickly through the rest of these slides, because I want to turn it over to Carolyn to the main subject. Just go back one slide, Carolyn. We studied for a year, 12 months, with a leading consulting firm. Several, actually. To look at the science. What has research shown how to reduce stigma? We're not going to just try something on our own, what Gary thinks or Carolyn thinks. No, it's what has worked. We studied 11 social movements, 100 pieces of published literature, hour-and-a-half interviews individually with 50 different experts who were in those social movements, and put together a science-based plan of what works. Next slide, please. The first thing we focused on was communities, the public. How do we change the public's view? And what the science shows is short videos, 90 seconds or less, with people living beautiful lives in recovery, to change the way the public perceives people with this disease. It's not someone in a back alley sticking a needle in their arm. Tens of millions of people are living beautiful lives, great parents, great families, great jobs, great neighborhoods. And we need to pick that in a way that changes views, and then get that out through 3 channels, and it works. Next slide, please. I'm going quickly. So we tried it in the state of Pennsylvania. Look at the results. In 12 months, we reached almost 4 million Pennsylvanians. And those 4 million Pennsylvanians in the top left changed their views across a set of measures by 15 points on average, 15.1%. Here's just a few samples. Look at look at social exclusion, the bottom one. I would be willing to have a person with opiate use disorder as my neighbor. Those 3.8 million people changed their views from 41% to 52% in just 1 year. Medications, look at the second one. Buprenorphine, it's an effective treatment for opiate use disorder, 26% to 39%. Naloxone, I would be willing to obtain naloxone that can reverse an overdose and save someone's life, 65% to 83%. The state was so enamored with, so impressed with these results, they extended it for 2 more years. Kentucky signed up instantly when they saw this data, and within the next 60 days, we'll be announcing 3 more states. We're going from 1 state to 5 states in a matter of 6 months since its results was released. Because its results are just proven. Next slide, please. Supporting and empowering our communities. That was another pillar of our work. Next slide, please. We created an education program for families, all based on science. 6 lessons, just 5 minutes each, that every family should have. Look at our partners distributing it out. Long list. We'll send you these slides later, so I won't go through it now. But next slide, please. Look at the results. For the people who engaged with this content, I know how to help someone who's addicted to drugs or alcohol. Went from 39% to 80%. I feel confident I can recognize the signs. 53% to 85%. I know how to reduce the risk. Prevention, 54% to 84%. On and on. This is powerful. These are real statistically significant results. This is not my wish. This is fact. Next slide, please. And also we have tons of great content, all based on science, highly curated on our website. Next slide, please. So with that, I'm going to turn it over to Carolyn, and I am 1 minute late. Over. So thank you all. And without further time, Carolyn, jump right into one of our bigger programs, quality measurement for addiction treatment.
Before we turn it over to Carolyn, I just wanted to say we have received a few questions already in the chat. I'm just going to save them until after Carolyn's presentation. Continue to put the questions in there and know that we'll get to them towards the end.
Great.
Thanks, Trevor, and thanks, Gary. And thank you to those who've already been engaging. I see with the Q&A and in the chat. Very grateful. Yes, great question, Charlie. I know we're going to get to that part about Maine. I'm glad you asked that. So starting off, within revolutionizing the addiction treatment system, we have a focus really across 5 different areas. So we have national standards of care, a quality measurement system, a needs assessment, as well as improving payment and coverage and educating medical professionals. And for this presentation, I'll be focused on those 3 kind of highlighted petals of this flower. I'll note that the other 2 petals are covered in our policy work. So just to be clear that Atlas really doesn't stand alone. This is one piece of what Shatterproof is doing. Now, in terms of what quality addiction treatment looks like, in 2018, Shatterproof released the National Principles of Care. So these are 8 principles of evidence-based treatment for addiction. They're derived from the Surgeon General's 2016 report on addiction, and they've been proven by decades of research to help improve outcomes for people with addiction. So we were very excited when we released these principles. It was with the sign-on of 16 national health insurers who agreed to identify and promote and reward care that aligns with those principles. That number has now grown to 23, but also we know that signing on is really only the first step in making a change. So just a quick sampling of who those insurers are, probably a few familiar names. And so we thought about it and thought, let's focus on quality measurement. And really, why quality measurement? As many of you likely know, there are already quality measurement systems for a lot of different products. I like to compare us to Consumer Reports, but for addiction treatment. You may know the CMS Nursing Home Compare or CMS Hospital Compare, the Leapfrog platform. We've seen that these platforms are already in existence, and also evidence demonstrates that they do really help to improve quality. The patients are using these online quality measurement systems, and that use really drives improvement at the facility level. And so with that, I know this won't come as new information to those of you on the webinar today, but we know that it can be incredibly difficult, as Trevor said, to find addiction treatment. Even for those of us working in the addiction space, I had a friend relapse recently, and I truly didn't know where I should take her to, where we should look for treatment together. It can be very difficult to understand what to look for in treatment. There's really limited, unbiased, or objective information. And beyond that, there's also harmful practices. Some of you may have friends who have experienced patient brokering and have actively been harmed by treatment centers. But we also know that there are good treatment centers out there who are working very hard to help patients. And so we want to make sure that people can find the treatment that they need. And so with that, we created Atlas. And I know Trevor explained the acronym, but when we say Atlas, just to clarify what we mean, it's a web-based platform, in other words, a website that uses validated measures to assess the quality of addiction treatment facilities. As I said, I like to sum it up as the Consumer Reports for addiction treatment. So the data are publicly displayed, so anyone can search for and compare treatment based on quality metrics. And on the back end, we have more detailed data. The goal of Atlas is really to move forward the quality of addiction treatment And that means also giving providers, states, and payers the information that they need to reward quality and prioritize capacity building. And so just to sum it all up, Atlas is really a one-of-a-kind resource. It's got a consumer-friendly needs assessment, transparent indicators of quality. It's not funded by providers and it's not pay to play. So we have both for-profit and not-for-profit providers. We have every level of care, a comprehensive list of facilities from outpatient through intensive outpatient, inpatient, and residential. It also includes educational content, as well as professional portals that I mentioned, and it's completely free and not for profit. When you don't make money off of Atlas, our goal is to help people find the treatment they need. So the Atlas website launched in July 2020, and I'll talk a little bit more about where in particular it launched. And as Charlie, for instance, wrote in the chat, it doesn't yet have Maine providers listed. That's a great question. So when we first launched Atlas, it was in 6 initial states: Massachusetts, New York, Delaware, West Virginia, North Carolina, and Louisiana. And we had $5 million in funding from a combination of philanthropy and also several payers. We developed our quality measures. We, of course, launched the website, as well as a continuous quality improvement virtual learning series, essentially a training for providers on how to use the data in Atlas to improve their care. And when we launched it, it was available to 13% of the US population. And so since then, we've grown. So we'll be expanding to 5 additional states in 2022, in 2023. You'll see here Pennsylvania, Florida, Oklahoma, New Jersey, and California. And we have several more states on the horizon. And I'll note that with those states on the horizon, we'll soon be funded to be available to more than 43% of the US population. So we're very excited that more people will have access to this platform. And so just to highlight that as of June 13th, we'll be live in 5 Northeast states with at least 1 more to come. So you may be wondering kind of what funds Atlas if it's not for profit. How do you sustain yourselves? And so we have a combination of funding from payers, state agencies, and foundations. And so I'll note that our payers don't have a governance role in the project. Really, their role is to fund us and help launch Atlas in their respective states or more broadly across multiple states, but they don't make decisions about who's included in the platform or the measures that we use, how we assess quality, et cetera. We work directly with several different state agencies, which is also a great way for us to work with states as an effective way to use, for instance, their opioid settlement funds. And then we also work with different foundations. So the data from Atlas comes from 2 main places. Maybe kind of wondering, okay, you assess quality, but how? So we use both a treatment facility survey. So this is an online survey that's administered to addiction treatment facilities. It looks at their processes, their staffing, their services, and we then validate that information. So we're not just taking them at their word. And it also includes a patient experience survey. So this is a series of multiple choice and 1 open-ended question about the quality of care that somebody received at a facility. And it's not, how soft were the beds? Did you like the food? But rather, how much did treatment staff show respect for what you had to say? Were you asked to involve your family and friends in treatment? So it's really questions that get at what was the fundamental quality of the experience. And I'll note that these patient reviews are completely anonymous. So since the website went live in 2020, it's been visited over 200,000 times. And we've collected data from over 2,000 facilities across 10 states. And so we've seen a lot of different trends in quality and a lot of different areas that may show opportunities for improvement. So for instance, we've noticed that there are not many facilities that offer collaborative care, that offer care that both mental and physical health care. So as many of you know, addiction is often associated with mental health needs and or physical health needs. And unfortunately, not many facilities offer those services combined. But we also know that that's really tough to do. And so clearly it can point to, for instance, potentially a need for capacity building in that area. And I'll note that facilities on Atlas right now have been viewed more than 32,000 times. So how are state partners already using Atlas? And so it's currently being used as a tool on helpline websites. So in states where there's an existing helpline, we don't want to duplicate the wheel. We will integrate with existing helplines or train staff so that they can use Atlas. It's also being integrated into a component of a county warm line. So for people who call just because they need somebody to talk to, they're having, say strong cravings or urges, or just really need help with their mental health, Atlas has been integrated as a component for those who might be ready to seek treatment. It's also been integrated into a state resource database for judges and court referrals. A court official, to use as a referral source from the state Supreme Court. So we know that many people are required to go to treatment due to the legal system. And so we want to ensure that they find the treatment that's best for them. And multiple payers across Atlas states have integrated Atlas for their patients when they're seeking treatment. So for instance, they'll have a page about finding a provider or finding SUD treatment, and Atlas will be linked there. And I'll note that we're also advertising the platform. We have billboards in multiple states as well as resource cards. And what we're looking at in 2022 and beyond is really using Atlas to understand where there are opportunities for improvement. We'd like to improve the measures. We'd like to expand to additional states, and certainly we want to incorporate new measures as the system evolves. And so before I stop, I wanted to just give a brief look at what Atlas is. So when we say Atlas, and this is what the website is, and anybody can visit the website at any time. I'll put it in the chat. It is completely free. And I think Anne made a really good point in the chat, which is that treatment may not be the right step for everybody. So really our focus with Atlas is to provide educational information and treatment quality information for those who may be ready to seek treatment or maybe just considering their options. Certainly it's not required that all of those who use go immediately to treatment, or, depending on your use, ever go to treatment. So I'll note that on the website, we have the Find Treatment button at the top. And we also have information so that you can learn more about treatment and really what to look for. You can learn about Atlas as a platform. You can meet the team that leads our work. Or you can take what you saw at the front page, that addiction treatment needs assessment. So although we only have facilities live in 6 states, the assessment is available to anyone, anywhere. And this is completely anonymous and helps you understand the right level of care for you or a loved one. We know that a lot of people, when they know that their loved one have addiction, they think that the only option for treatment is 12-step or 30-day rehab, which we know isn't accurate. There's really a spectrum of services in addiction treatment. And so we want to help people find those services. And so you'll just note that it's pretty straightforward questions about you or your loved one's use and needs. And once you take the assessment, then you can find treatment and search for facilities. And so, as we mentioned, we don't yet have facilities in the state of Maine, but we do across the Northeast. And you are able to search in any of the states that were live. I'll also note that Atlas is not restricted by state boundaries. So if you happen to search, say, in the state of Massachusetts, or if you search, say, in the state of New Hampshire, even though no New Hampshire facilities would pop up, Massachusetts facilities that are close enough would appear as well. And before I close things, I just want to note, let me pull up my PowerPoint again, that for those who are seeking treatment, our goal in the states where Atlas is not yet live is to really emphasize the key components that you should be looking for when seeking treatment. So you don't have to be in an Atlas state to use the information from Atlas to find the care that you need. And you'll notice that in the kind of last slide, I linked to the Shatterproof Find Help page. And to Gary's point about really educating and empowering communities, this page is accessible to anyone and includes information about the type of treatment that you should seek, whether or not it's time to go for treatment, what sort of questions that you might want to ask a provider when seeking treatment, and even how to pay for treatment, which we know can be really daunting, especially at a time when you're so stressed and seeking care. And so I will pause there. Gary, did you want to say a few words?
No, I think you covered it all beautifully. I have nothing to add. We're just here to help people. And I would also say that we're as a resource to states and to families. And as any of you who are listening here in any way look at Atlas and have suggestions to make it more useful to either families looking for treatment or for the state to use how to improve the treatment system in their state, we would love suggestions. And one other thing that I don't think you mentioned, Carolyn, in case I missed it, the site that you're going to look at, that Carolyn just demonstrated for you is being completely redone this year. It actually started this week, and it'll be completely redone with numerous focus groups all along the way. Build focus groups, build focus groups, build focus groups, and it'll be launching in the first week of January, probably, or the second week, to make it the user experience, significantly better. So thank you, and we look forward to helping and partnering with the state of Maine in any way that we possibly can.
Thank you both. I really can't say enough how great this work is, how valuable this work is, really, for people all around the country, but especially in Maine here, where this problem is so acute. I did notice that we have Gordon Smith, who has joined us. Welcome, Gordon. Gordon leads the governor's opioid task force work on prevention and recovery. Did you want to say anything, Gordon, or did you give you an opportunity to?
I wanted to make sure that you handled any questions, Trevor, from the participants. But if there aren't any questions, then I do have some concluding remarks. Yes.
We do have quite a few questions, actually, and great. I have a number myself. So that's great. We'll try to save a few minutes for you at the end to make a few remarks. That's all right. So we're going to get to some of these questions in the chat here. This is a really interesting one. Do any of you feel that increasing polarization, like political, cultural, ideological, or regional polarization, is leading to increased isolation and thus greater rates of addiction, overdoses, suicide, as well as decreasing open dialogues on mental health and addiction? So I guess, is the polarization that we're seeing as a country, is that adversely impacting the opiate epidemic?
Sure, I'll start, and Carolyn, feel free to jump in. We haven't seen increasing polarization related to a political party at all. It's real. The social isolation was created for a needed reason related to COVID. We needed to isolate as a country for a certain time period, and that we had to do that for COVID to save people's lives. But you could not have created a worse scenario for people with a substance use disorder. And I'm not saying we shouldn't have done that. We had to do that, but that's exactly the worst thing for someone with a substance use disorder. The social isolation, where you're not going into an office, you're around people, you're alone in your apartment or your home. 2, the anxiety that comes with, am I going to lose my job? If I'm in the service industry, am I going to be able to afford my rent? All the anxiety that comes with that. Treatment programs closing down appropriately because they didn't want to infect people with COVID. Well, it was a perfect storm, horribly, for people with a substance use disorder. Now, a lot of that will start to diminish now, but the effects of that for those with a substance use disorder and our children who didn't go to school for a year and a half are going to be felt for a while. Carolyn, anything to add?
Sure. I think this is a really great question, as I know that it does feel like there's a lot of increasing political polarization. I think to build off of Gary's point, we've seen that within the addiction landscape, that there is fortunately a lot of agreement around the fact that we do need to do something to support communities with addiction. And I think that that fact certainly continues. And I think that for better or worse, as the epidemic continues, I think we will continue to see people recognizing the importance of supporting those with addiction and finding treatment.
Trevor, I'll chime in on a state perspective on that question, which is a very interesting question. And we have not seen this problem get worse because of the polarization of our politics, in my opinion. I very frequently say that one of the things that I love about the work is that it truly isn't partisan. That even if you look at some of our most recent work in the legislature over the Good Samaritan law, there were 8 Republicans that voted with Democrats in the Senate to give that a fairly overwhelming 22-11 passage. So as Gary so well knows, this disease does not discriminate. And the number of Republicans who approach me in the halls and talk about family members or friends, Democrats, Republicans, and independents, it is truly the one issue that does not divide along party lines. And I agree with Caroline that I think everybody wants to make the situation better. Of course, the parties have different approaches sometimes to certain policy issues, but I've never felt that it was that this was a polarizing issue. It's a unifying issue to fix our families and our communities and give people options.
Yeah, I mean, same with me. And I'll just add, because I've got the perspective of working with multiple states, not only within the state of Maine. I think Gordon said it best. It's a unifying issue, not a dividing issue.
Yeah, great. Thank you. That's really helpful. I think, Gordon, what you said is this disease doesn't discriminate is spot on. I mean, race, color, creed, political affiliation, everybody, I think, has been impacted by this. So another question here, and maybe this isn't squarely in Shatterproof's wheelhouse, but can anyone speak on the problem with insurance carve-outs wherein certain treatment modalities, like spiritually based or holistic treatments, might not be covered despite largely showing efficacy? And I think I would add to this question, because you've done so much research in this, what is the most effective treatment modality? Is it medication-assisted treatment, or is it holistic treatment, spiritually based?
Sure. Yeah, I'll jump into that, and Carolyn can add to it. First of all, what's driven a lot of interest in this area and support for our work is the opiate epidemic. Having said that, let's not forget that about 90,000 people die every year related to alcohol. And so our work is for all addiction to any substance, whether it's alcohol, opioids, or other drugs. So that's kind of bullet point number one. As far as effective treatment goes, it really goes back to isAtlas. When Carolyn showed that first screen, the first thing was take an assessment. Because so many people, you can go to a treatment program that's doing all the right things, but right things for who? Every situation is different. So we approach, and the problem with our system today that we recognized, after we got the funding to build and launch Atlas in the 6 states, we then looked at another issue. We can improve the quality of care, but we got to get people to the right care that's appropriate for them based on their situation. So, and the American Society of Addiction Medicine has a very complicated, comprehensive, wonderful assessment that's delivered by clinicians to a patient to titrate the level of care they need. The problem is it's delivered mostly when you're already at a treatment program. It's too late. And you can call 10 treatment programs, and we hang up off this webinar, and call 10 residential treatment programs and describe someone that definitely needs outpatient. And everyone will say, yeah, it's right for us. And I'm not criticizing, it's just the way it works, right? I'm not here to throw any stones. So we approach the American Society of Addiction Medicine with that issue. You have the great assessment, but can you work with us and develop something that's not for a clinician to a patient, but for a consumer that can answer less than 15 questions, less than 10 minutes, consumer-friendly language, just to get them down one of two paths, outpatient or residential. That's it. And then once they're there, they can get your comprehensive assessment. They agreed. We spent 1.5 years building it on their science. It's all based on science and research. It's not what I think. It's their science. We were the driving force to get it done. And they made it better than my original question to them. It's actually 5 levels of care: hospitalization, residential, intensive outpatient, or you don't need treatment, just get an intervention. So it's 5, depending on how you answer those 13 questions, and it is less than 10 minutes, completely confidential. It'll give you a recommendation of 1 of 5 levels of care. And they made it better in an additional way as well. In addition to that recommendation, you get recommended additional services. Do you need medication for opioid use disorder? Do you need medication for alcohol use disorder? Do you need mental health services? And so you'll get that. You just finish the 13 questions, you hit submit. Within a second, here's your recommendation. And then when you search for treatment in your state, it will only list the treatment programs for you to compare features to that have those recommendations. It will only show you intensive outpatient if that was the recommendation. And it will only show you intensive outpatient that has the additional services that were recommended to you. So to answer that question, it depends what you have, for that person. I will also say that there's another distinguishing factor that I think it's important for people to realize. I had a call on this yesterday. I've had a call once a week, actually, on this new thing that's coming up that's got some good vibe, it's got some good case studies on it related to psychedelics, for example, or XYZ, or this. We're Shatterproof, proof, science. I'm not the arbiter. I'm not a researcher. I'm not an arbiter of what is good care or not. Once we determine what level of care you need and what additional services, our standards of care, that national principles that Carolyn mentioned, is all based on either FDA approved or recommended by HHS. That's it. And if it doesn't, if someone comes up with something good, whether it's psychedelics, whether it's holistic, whether it's this, if it's recommended by HHS, which means it has to have numerous randomly controlled trials that's proven to work, we recommend it and it builds into our system. And if it doesn't, I'm not saying it's not good. There could be a great holistic system. There could be a great psychedelic. There could be a great XYZ. I'm not saying it's not effective. I'm not saying we can't build it into our programming until it is either recommended by HHS, by the federal government of the United States, DEA, FDA approved, or recommended by HHS as a therapy that has randomly controlled trials proven to work.
Great, that's really helpful. Excuse me. Along those same lines, you had mentioned the cost barrier being a really significant problem to treatment. Do you assess the variation in cost across facilities when you're evaluating them, or do you have any plans to look at the cost of treatment to help people find facilities? Or
sure, what we do is people can search for, they can filter their search by their insurance plan, or if it's Medicaid, or if it's no insurance, they can filter by those and find the treatment programs that are appropriate to their particular payment model or where they're covered. No, that's bullet point number 1. Bullet point number 2, our policy team is working on payment models. there is a particular, and I apologize, I don't know right now whether Maine has adopted this or not, but we looked at payment models for our policy team to focus on a few years ago. And we discovered or became fully aware of and researched it, the collaborative care model, which basically is, instead of a provider being reimbursed for a session and another session and another session, they're reimbursed by a team of 3 people to take care of a patient. And it's called the collaborative care model. We can send you a report that we published on this, and we partnered with an organization called I'm forgetting, the First Path, I think, or something like that. And they're focused on commercial plans covering this. We're focused on Medicaid plans covering this. When we started looking at it, only 14 states had even turned on the CMS billing codes. And by the way, the collaborative care model has proven to improve outcomes by 47% through randomly controlled trials. Only 14 states were even covering the codes. So we have since got many states to adopt the codes. Massachusetts, closest to you all in the Northeast, California, Texas. We have half a dozen other states we expect to turn on the codes in the next 3 to 4 months, including Connecticut here in the Northeast. I don't know if Maine has the codes turned on or not. We can let you know, but we're working to change payment models to improve outcomes. And this is not going to cost the state money. It's going to save you money because people will have better outcomes and help the people in your state.
Sorry.
Go ahead, Caroline.
Sure. And oh yeah, thanks, Gordon, for writing that. And I'll just say briefly that we also look at what point in treatment facilities tell patients about how much it will cost, because we know that that's definitely a big barrier, is that patients don't know sort of what they're getting into until after they've received treatment. So just wanted to note that quickly.
Great, thank you. Yeah, unfortunately, I don't think we're going to have time to get to all of the questions here, but Gordon did note in the chat that we will get answers posted on the website to all those questions. So check back for that. I'm sure you'll all receive a follow-up email that will direct you to the right place to find those things. With the few minutes we have left, I did want to give Gordon a chance to make some remarks. So,
but we've only got a couple minutes. First of all, I want to thank you, Trevor, and the Health Purchasing Alliance for putting this together, and particularly thank Caroline and Gary. So it's a terrific opportunity to get Shatterproof in Maine. We'll continue. There's some questions in the chat, of course, about, well, what do we have to do to get Atlas in Maine? And we will absolutely pursue conversations with Shatterproof. We've also talked with them about their anti-stigma campaign in Pennsylvania. At times in the past, we've not had funds to be able to move some of these things, but we do have the settlement money coming and some new sources of revenue. And it's a very credible organization that we'd love to work with. One person can really make a difference, and Gary's that person. I wanted to announce that we will do a webinar on the first Friday in June, as we always do. And the subject matter likely will be what we're doing to respond to not the constant surge, but the continuing increase in the number of overdoses, both fatal and non-fatal. We have about 6 things that we're doing. I think it's probably time to share that with in depth, get some feedback from everyone. I'm very excited about some of the things we're doing. And we'll also preview, of course, the Governor's Summit on July 11th, when we're in Bangor in person. And that June webinar will give us a good chance to tell you who's speaking, the breakout sessions, and we look forward to that program on June 3rd. So June 3rd, July 11th. Again, Trevor, Caroline, Gary, hope we can get you all to Maine. Trevor's already in. And really appreciated everything you've shared with us today. And we'll follow up, because we'll also need your help to answer these remaining questions.
Yes.
That sounds great.
Everybody have a great weekend, and
thank you.
We'll see you in June. And Gary, I hope we get to meet.
Great. Likewise, Gordon. Thank you. And
Yeah,
thank you,
thank you all so
Trevor.
much.
And thank you for all of you for joining. Thank you.
Thank you all so much.